Okay, how many mm superior to the the attached gingiva are you supposed to go to place the incision?
That's for you all. 5 mm. I think in dentistry everything is 2 mm or 5 mm. Very easy. The answers are not very difficult. So you just say 2 mm when you think it is around that much, and then you say 5 mm, you will be right. Yeah, nausea and vomiting is the side effects.
Nausea and vomiting.
Yes.
Let me ask you one thing.
Yes.
From transgenic acid injection, right?
Yes.
Can you give your insights on hypovolemic?
Yeah. So again, maintaining hypotensive anesthesia to the procedure is
in Lefort 1.
Yeah, so maintaining hypotensive anesthesia is again very important. So we do what? So I'll just give you all a brief on how we do our orthognathic procedures. We infiltrate both the maxilla and the mandible. We finish exposing the mandible, cut the mandible, just make the cuts, osteotomy cuts, don't split the mandible. By then the infiltration has acted well in the maxillary area. At this point, when we are cutting the mandible, we start asking our anesthetists to make sure that the mean arterial pressure is low in our range. So it's not the systolic pressure. It's not like you keep asking the systolic pressure to keep going down. It's the MAP that is of importance. Once that is under your level, you can actually see your field is quite dry. And after you've down fracture, you ask them to normalize it. That's the routine, and there is nothing more in it.
Afrin, do you have a presentation for your discussion? Can you do that now? No, okay, no, wait. If you have a presentation, you can do it. In the meantime, you can just probably ask him questions. Part of those questions. Because that conjunct is getting ready, so I don't want to waste time. So you okay, sir?
Yeah.
Okay.
Okay, do we have any questions from the audience till then?
Audience, please ask questions, because otherwise there's no point in us coming all the way here. It's easier for us to keep it more interactive. I don't see how. No question is a silly question. You can ask whatever you feel is right.
Innocent question from
Please
innocent youngster.
Yes.
I want to talk about that small incision.
MIS, yes. Yeah,
So
please.
you can go till the pterygomaxillary fissure.
Yeah, so again, like I said, that.
So don't you think by retracting it over judiciously, it will anyway cause some soft tissue histogenesis, and you will.
So I will summarize whatever I have understood, and we both smiling here. So the minimally invasive orthognathic surgery is a concept that has been floating around for some time now. What does it mean? It is trying to reduce the post-operative edema and facial expression issues after orthognathic surgery. For that, the incision should be very small. You may or may not have specialized instruments to retract, but the incision should be small, almost just around one tooth dimension on both sides. Now, can you reach the pterygomaxillary junction? No. Do you have to reach in their concept? No. So what they do is they do a twist down fracture. So when that was demonstrated, both of us shuddered, because if you kind of twist, you may have an anterior wall fracture. But however, I'll tell you why it is applicable in some cases. When you're doing minimal correction like VME, or not bringing the maxilla forward too much, your corrections are within 2 or 3 millimeters for already good-looking people who just want to look slightly better. I think a minimally invasive orthognathic surgery concept works very well. I think she's giving me cues that he's
One more thing what I want to
already.
add here is, what happens when sir was talking about this thing, minimally invasive. Basically, again, this fat will create one problem. That is a thing, but it should not be minimally so that you can't approach. So again, it depends on case-to-case basis, and all your structure you need to preserve.
If you
because
maintain
then
the
again,
periosteum, you'll never get fat. That's the truth. To maintain the periosteum, you go down and you'll never get fat. But you can get fat too.